Hi, Alistair. Good
Hi,
afternoon.
Krish.
Yeah,
Hi.
it's lovely to see you. We all had a long day on a Friday afternoon. Uh, I'm Mani Krishnan. I'm an old age psychiatrist. We've got Professor Alasdair MacLullich, who is a geriatrician. We're just going to have a kind of a brief chat on uh, with our preparation for the World Delirium Awareness Day on 16th of March. We're going to use a bit of reflection as a practicing clinicians, as a psychiatrist, as a geriatrician, what is the role of medication in management of delirium? So, Alistair, do you want to start?
Yeah, so this is a really interesting area because we know from surveys and from our day-to-day clinical experience that lots of people routinely prescribe drugs like antipsychotics whenever they see a case of delirium. And I've certainly visited hospitals where that's happened. And yet there's a gap between what we see in practice and what the evidence and guidelines say, which is that there's no concrete evidence favoring the use of antipsychotic drugs to treat delirium. And what I mean by that is when somebody has a diagnosis of delirium, they're just put onto a drug as part of the treatment package for delirium. That's not to say that there isn't a role for drugs in delirium as reached by expert consensus, when somebody has intractable distress or agitation. But I think it's a strange position that we're in the field where there's huge variability in practice across the world, where there's a habit of using antipsychotics routinely in some places. And I just worry about that. I think that there's maybe a lack of discussion about it, but at the same time, I don't want to be too restrictive because I think there is a restricted, small role for drugs in delirium care.
Yeah, I agree. And again, I don't think I would go just say no medication whatsoever. But at the same time, my biggest worry, especially seeing frail old persons, patients with multiple comorbidities, it is my fear of medication, the right medication for the right reason, without even trying the non-pharmacological, because there's this old chestnut people saying that you can't treat every delirium with non-pharmacological, but without even trying sometimes. And again, we will probably able to examine, through our reflections of various cases we have gone through over the years, giving wrong doses, continuing medication beyond the delirium episode. And For example, using medication as a treatment is something I worry as a clinician, because there isn't, again, correct me if I'm wrong, Alistair, from your academic experience, there isn't an evidence-based specific treatment modality like a medication treatment that's directly as a treatment for delirium. Some of the medications we use are sedatives, which are used as a in psychiatric term, rapid tranquilization. My worry is that if somebody says delirium and tablet, again, I don't mind saying haloperidol, it almost thinks that even if somebody has no symptoms, if they have a delirium, somebody documented, we fought so many years for them to document delirium. Next thing is they are documenting medication, which is my biggest concern. Would you agree?
Totally agree with that. It's very well put. That in fact it's an unintended consequence of our campaign for better delirium detection that some
Absolutely.
people have been concerned. Yeah, that we've created an epidemic of haloperidol, prescribing, which is causing all sorts of side effects, which was never our intention. So absolutely right. There's no evidence supporting just use of a drug in response to delirium diagnosis. Um, where there is some expert consensus is use of drugs to treat elements of delirium or features which are common in delirium, such as distress that doesn't respond to non-pharmacological approaches. I work in orthopedics, so I see hip fracture patients pretty much daily. And, people are often distressed and restless in that situation, but pain is, a very common cause within delirium. So the haloperidol is a bad treatment for pain. It doesn't work for pain. So when somebody's agitated, for want of a better term, the first thing to check in orthopedic patients is pain. And more than half the time it's pain. in at least another 20% of patients I see, it's urinary retention that's the cause of the distress. And again, haloperidol is a bad treatment for urinary retention. It really doesn't work, and I know I'm sounding a bit, making a joke of this, but honestly, that's what you will see sometimes. You'll see people try to use antipsychotics to treat agitation, distress, without trying other things first.
Absolutely.
On the other hand, there are patients who have awful, hallucinations and fear. I've seen 2 or 3 this week in whom all the other things were done and antipsychotics seemed to be the right thing and they seemed to respond to them. So I think I'm not against the use of these drugs in delirium, but I think they need to have a specific reason for it. As you say, the symptoms.
Absolutely. And as you rightly pointed out with pain, especially people who are confused, some of our patients with delirium superimposed dementia, putting PRN as required painkiller is absolute crime in my dictionary, because how are they going to ask, I have pain, especially post-operative patients? So pain is something very important. Constipation, another one commonly missed. I see so many times it's a cliche and people keep thinking, why is Dr. Krishnan keep on asking about constipation? Because they say constipation checked, but nobody bothers to check again. So that's something I find. And other thing you rightly mentioned about the haloperidol, some of them get high doses of medication. We have talked for 7 minutes, but we still are constantly reflecting some of the ill effects. And people leave them on medication post-delirium, like, they are discharged, and they are the patients I see in the community where they're coming stiff like a board or developing multiple side effects. So I do think that we need to be very careful on that.
Yeah, I mean, I was shocked to find that there's several papers that show that people are discharged on antipsychotic drugs that have been prescribed in the context of a delirium, and no one has stopped those drugs, on discharge. So they're on them for years. I mean, it's an absolutely scandalous situation, without any proper scrutiny. And in my opinion, outside of, certain contexts, perhaps the ICU and intubated patients, that's not really my area of work. But outside of the ICU, 2 days of treatment with antipsychotics, then review and usually stop would be the thing. And I think if somebody's on haloperidol for 2 weeks, it's not working, and other approaches need to be taken. So I think use of drugs has to be super mindful. We have to stop and think, why am I prescribing this drug which has no evidence in favor of being a general treatment for delirium? What is the indication for it? What symptoms am I attempting to treat? And have I looked at other causes of those symptoms first? And also, have I limited the dose and how long the patient is going to be on these drugs for?
Yeah, and then I thought I'll just share like a little, just one slide to, it's a balanced view needed. I think we are not against medication, but we are not for medication either. But consider the risk. What is the risk of giving medication or not giving the medication? And also consider the risk, as your patient you mentioned, if somebody is extremely distressed, extremely having psychotic episodes that are distressing the patient, distressing the family, distressing the staff, we do have that balanced view. But think of side effects, prescribing, continuing, and stopping. We need to think of the side effect, but just be mindful. If you are using some of these medications like haloperidol, it is a chemical restraint. So in your own visualization, think of it. Would you like to strap them up? If the answer is no, you shouldn't be giving that medication. I think that's how I see it. I don't know. Do you have any view on that, Alasdair?
I mean, absolutely right. I mean, you are restraining people to an extent, especially if you're using bigger doses. And it's really anti the principles of medicine to be doing that, to doing it for your sake rather than the patient's sake. And wherever possible, we shouldn't be restraining people. We should be allowing people to be free to move around, to do what they want, up to the point, where truly there's a threat to safety. But somebody just wanting to walk around the ward and explore, and mobilize is a perfect natural thing for someone to do, and that is not an indication for antipsychotic drugs. So. Yeah, so I think I would encourage people to look at the evidence. There's plenty of good systematic reviews out there, meta-analyses. the guidelines in the UK and from NICE and Scottish Intercollegiate Guidelines Network, and multiple other guidelines around the world. Australian Care Standard, Ontario has produced some good guidelines recently, the American Geriatric Society, you know, palliative care ones, they all give the same message. And yet, so we need to work hard, I think, as people advocating for good delirium care to restrain the use of drugs, you know, not to totally say they can never be used, but to use them sparingly and very mindfully.
Absolutely. I think, again, don't forget the side effects. Like, you know, sometimes one of the side effects, like akathisia caused by some of the antipsychotic, will be like restlessness. So I have seen in clinical practice, people just giving more haloperidol, getting more akathisic, thinking that they're agitated. So you've, and then there are, you know, if you scan the QR codes, it will take you to the American Delirium website or our videos, and hopefully you will all join us in our promotion of the World Delirium Awareness Day. But our theme this time is from awareness to action. We've been very aware now, thanks to Alasdair and various leaders in the world, but we need to act now. We need to do the right thing for our delirious patients, and hopefully we'll all together one day conquer delirium. So thank you.
So much. It's been good to chat to you.
Thank you. Good to chat to you.